feel free to get started with the meat. So that slide in between was the logo for the National Curriculum of Reproductive Psychiatry, the NCRP, a nationally developed curriculum on various subjects, and much of this material is gleaned from that program. Okay, so anxiety is a very broad term. When talking to patients, I often distinguish between anxiety with a lowercase a and anxiety with an uppercase A. The former being the normal human experience that we all have, and the latter being a disorder that impacts one's ability to function. So there are several disorders under the broader category of anxiety. A few of the most common ones are listed here. So generalized anxiety disorder, mostly referred to as GAD, which can be plus or minus panic attacks. Obsessive compulsive disorder, or OCD, panic disorder, social anxiety disorder, and phobias. This lecture will be talking about anxiety disorders as a whole, with a bit of special attention paid to OCD. So, like I said, it's very broad and it's very common. They are underdiagnosed and undertreated, both in the general population and the perinatal period. There's up to a 40% prevalence in pregnancy and postpartum, with about 10% of women meeting criteria for GAD, which is the most common one. Honestly, I've never met a new mom who was anxiety-free or a pregnant woman who was anxiety-free. So some level of anxiety is essentially a given. That's the rule rather than the exception, but the extent to which it impairs her life, so at work, at school, bonding with child care, social interactions, etc., that's what is variable. Anxiety is highly comorbid with depression, about 80%, and insomnia. And insomnia is particularly important because it's an independent predictor and risk factor for decompensation of psychiatric illness, and anxiety included. Risk factors, the biggest one is a history of anxiety disorder, also smoking. The rest of these you can see a theme: first child, previous negative childbirth experience, previous miscarriage, prematurity, a child in the NICU. All of that creates stress and anxiety and worry around a pregnancy that can develop into actual disordered anxiety. Medically complicated pregnancy is also a big one. There's evidence that anxiety disorders are 5 to 7 times higher in women with moderate or high risk pregnancies as compared to those with low risk. Okay, so you might have heard this before, but the biggest, or one of the biggest ideas in perinatal psychiatry is that there's no such thing as a non-exposure. Medications are an exposure, active illness is an exposure. Both come with a set of risks, as evidenced in the literature. Some have more data than others, but what we have, we review those risks and have what we call a risk versus risk conversation in order to decide what the best treatment is, whether to start a medication or what medication to choose. The risks are typically broken down into obstetrical, maternal, and then fetal and or child. And here is an example of the list of risks we have related to exposure of anxiety in pregnancy. So hypertensive disorders of pregnancy, including preeclampsia, preterm labor, preterm delivery, development of depression, which particularly postpartum depression, which exists even after depression in pregnancy has been controlled for. Low birth weight, and then possible associations with behavioral developmental issues and childhood anxiety. Just one reminder, we all have anxiety, and this isn't meant to scare anybody who's experiences anxiety while pregnant or after delivery. These risks are not applicable to mild anxiety or worry. This is when we're talking about the moderate to severe disordered anxiety. All right, so like I mentioned, I wanted to take a minute to talk a little bit more about postpartum OCD because it's really common, but not understood well and not normalized to women. There's a much higher prevalence of OCD in the postpartum period, estimated to be around 6.5% in comparison to around 2% in the general population. Subthreshold symptoms are even higher, what we have coined in our clinic as sort of an OCD flare to anxiety. The obsessions are directed at their baby and can range from, say, fear that the baby will fall ill, so then they compulsively check their temperature or wash their hands, don't let anybody else interact with the baby, to graphic, violent, or even sexual thoughts directed at their baby. They rarely divulge this unless directly asked because they're worried their children will be taken away. DSS will be called. They'll be taken to the hospital. And in reality, the thoughts are highly, highly distressing and upsetting. They're intrusive. They don't know why they can't stop thinking about it, and they feel like they've gone crazy. Examples of what I've heard multiple times are intrusive thoughts about smothering their children, stabbing their children, throwing them down the stairs, falling with them down the stairs, throwing them out a window. And you can imagine if otherwise you are, have your mental capacity and faculties about you, those can be very, very disturbing and distressing. These women are not psychotic. They are not a danger to their children. This is not postpartum psychosis. These thoughts are what we call ego dystonic, meaning they know that there's something wrong and can feel that conflict within their mind that the thoughts are causing them, which is in opposition to what we call ego syntonic, which the thoughts are in line with their concept of self. This can certainly apply to psychosis, schizophrenia, postpartum psychosis, but also illnesses like anorexia, which may be a little bit easier to conceptualize. For treatment, non-pharmacological approaches, particularly therapy, is going to be recommended for essentially anyone with an anxiety disorder and is acceptable to be the standalone treatment for women with mild to moderate anxiety. As we discussed a few slides ago, in this subset, the risk of medication exposure, although it's small, probably does not outweigh the risk of illness exposure because the illness is mild. Data supports essentially all therapy types, as well as modalities such as yoga, acupuncture, and others. Even though this final bullet point is last on the list, it's really important, but can sometimes feel really challenging. Just having a practical discussion about their support at home, especially overnight, can be really impactful. For pharmacological treatment, SSRIs are the first-line treatment for all anxiety disorders. If they've taken something in the past which has worked well for them, I will almost always restart that medication. Other things we consider are listed here, particularly past response to medication, like I already mentioned, but reproductive safety, so what data is there available, side effect profile, patient preference. If they have a parent or sibling who has done well on a certain SSRI, that's also a good place to start. The goal of treatment is always remission. Many women and providers have this notion that, okay, I'll take something, but only a small amount so that I'm not exposing my baby too much. And they lose track of or lose sight of or just don't know that the illness is also an exposure. And if someone is taking a medication, but it's not fully treating the issue, they're actually creating a double exposure or a potential double exposure to the fetus. So lowest dose is always ideal, but lowest effective dose is really the key. Almost all, typically max out one medication before adding a second. Benzodiazepines do have a role in some cases, although we rarely start them in pregnancy. It's mostly women who are already taking them and become pregnant. I didn't want to go too far in the weeds of medication because I wasn't sure what all would be relevant for the attendees, but happy to answer more specific questions if there are any. And then sleep. Sleep is very hard. But addressing and managing sleep is critical. Often with treatment of anxiety, sleep will improve. If they're ruminating, anxious, spiraling thought process is better. They usually can get better sleep, but sometimes not. And I do recognize the limitations when life involves a newborn who needs to be fed overnight and needs to be tended to overnight, but that's certainly not a reason to ignore the problem. There are several angles at which to approach sleep, both through therapy, pharmacologically, or just practical discussions similar to the support discussion. Sometimes this does involve a discussion around breastfeeding. I'm aware of and support the pediatric guidelines, and I also see a lot of women whose mental and physical wellness drastically improves when they make that guilt and shame-ridden decision to stop breastfeeding earlier than originally planned. And at the end of the day, mom's wellness equates to baby's wellness. So that's the end of the brief didactic material before we move on to the case. Rachel, do we stop here for questions first?
Yeah, let's have about 5 minutes of questions. We'll make sure to monitor time and then we'll move into the case. 1 second.